Good morning, good afternoon, and good evening to everyone who joins us from around the world. We're so glad you're here.
It's wonderful to be with you all again.
This is Andrew and Renee. Welcome to the Stack series.
And we have quite a topic to unpack today. It's a big one.
It really is.
Yeah.
Usually when we look at medical topics, we're sort of in the fix-it business.
Right.
How to set a broken bone, how to target a tumor, how to manage diabetes. It's all very reactive.
It is. We wait for the problem, then we solve the problem.
Exactly.
Exactly.
But today we are exploring a question that kind of upends all of that. Is aging actually a disease? And can, or maybe even should we cure it?
It's a question that on the surface feels almost, arrogant to even ask. I mean, for basically all of human history, getting old has been seen as the ultimate inevitability.
The one thing you can't escape.
Exactly. It's the natural fading of the light. You're born, you grow, you age, and eventually the machine just stops. It's the cycle of life.
It's the one thing we all have in common. Death and taxes, right? But what if I told you that there's this massive shift happening right now? And not just in some, fringe science lab or a billionaire's bunker.
No, this is mainstream.
It's happening in major policy centers, in huge investment funds. And it basically says, we've been looking at this whole thing wrong.
It's a fascinating pivot. You can really see this battle playing out in real time.
Between what, exactly?
Well, between the traditional view of aging as a natural process.
Something to be accepted with grace.
Yes. And this new emerging view of aging as a treatable condition.
And this isn't just some philosophical debate for, late night chats in a dorm room. The stakes here are incredibly high.
Oh, incredibly high.
We're talking about trillions of dollars. We're talking about something called a longevity dividend that could completely reshape the global economy.
We're talking about a specific drug, a really common one, actually, that costs pennies. That might just be the very first anti-aging pill.
And we're talking about a huge controversy that blew up at the World Health Organization just a few years ago. One that almost changed the way every single doctor in the world codes a diagnosis.
It really is this collision of biology, economics, and ethics. And I think to understand where we're going with all this, we really have to strip away our own assumptions.
Okay.
We have to look at the foundations. What do we think we know about getting old? Because for a long, long time, medicine has been playing a very specific and, frankly, a very frustrating game.
The whack-a-mole game.
Precisely. That's the perfect term for it. Think about how modern medicine is structured.
It's all specialists.
It's all specialists. You have a cardiologist for your heart. You have an oncologist for cancer. You have a neurologist for your brain.
Yeah.
And the way we treat health is by waiting.
Waiting for a mole to pop up.
We wait for a disease to appear, and then we try to whack it down.
Right. You get high blood pressure, whack. Here's a pill.
Yeah.
Your blood sugar is high, whack. Here's some insulin.
You find a tumor, whack. Chemotherapy.
And to be fair, we've gotten pretty good at whacking some of those moles.
Oh, very good. We've extended life expectancy significantly over the last century. No question.
There's a problem with the game itself, isn't there? There's this statistical reality that's actually quite sobering.
There is. If we cured all cancer tomorrow, completely wiped it off the face of the earth, do you have any idea how much that would extend the average human lifespan?
I think I've seen this stat, and it's shockingly low. Something like, 3 years?
It's about 3 years, maybe 4, if you're lucky.
That's it.
That's it. Because if cancer doesn't get you at age 75, well, the heart disease is waiting right there at 78.
Or the Alzheimer's right behind that at 80.
Exactly. The underlying risk factor for all of these things is still there, just ticking away in the background.
And that risk factor is aging itself. The machine is it's breaking down.
It is. And this brings us to what's called the geroscience hypothesis. This is the new paradigm, the new way of thinking that really challenges that whack-a-mole model.
So what does it say?
Geroscience posits that aging isn't just, the passage of time on a calendar. It is a biological process.
Something real and measurable.
Yes, a specific set of mechanisms that go wrong inside our cells. And this is the crucial part. It argues that this one process is the root cause of all those other diseases.
Okay, so the theory is, if you can target the biology of aging, if you can somehow slow down that underlying decay.
You don't just delay cancer.
You delay heart disease, you delay dementia, you delay frailty, you push everything back at once.
Everything, all at the same time. I've heard it described with a dam analogy, which I think is really helpful.
Okay, let's hear it.
Imagine a big dam holding back a massive reservoir of water. That water, it's all the diseases of aging, cancer, Alzheimer's, all of it.
Okay.
The whack-a-mole approach is like running around with a roll of duct tape trying to plug individual leaks in the dam as they spring up.
Right. You plug one leak, the pressure builds, and another one just bursts open a few feet away.
Yeah.
You're always chasing the problem.
You're always chasing it. And geroscience says, forget the duct tape. Let's reinforce the concrete.
The dam itself.
The structure of the dam itself. If you can reinforce that, if you make the concrete stronger, the leaks don't spring up in the first place. You maintain the structural integrity of the whole system.
Okay, so reinforcing the concrete sounds great in a metaphor.
Right.
But we're biological organisms. We're not concrete structures. So we have to understand what that concrete is actually made of, what is physically breaking down inside of us when we get old. Because I think for most people, aging is just, wrinkles and gray hair. But under the hood, it is a lot messier.
It is infinitely messier. And this is where we get into what are called the hallmarks of aging.
The hallmarks, okay.
This is a scientific framework. It was originally proposed by a scientist named Lopez Otin and his colleagues in this just landmark paper. And they basically categorized everything that goes wrong.
At a cellular level.
At a cellular and molecular level, they identified these specific mechanisms, these distinct pathways that drive the aging process forward.
I really want to dig into these because this is where the science gets tangible. It stops being this abstract idea of getting old.
It does. It becomes a list of problems to solve.
So let's talk about the first one, the one that always kind of scares me. Genomic instability.
That is the foundation of the house, really. Your DNA is the instruction manual for your body.
3 billion letters long.
3 billion letters. And every single day, your cells are either reading that manual to build proteins, or they're copying that entire manual to make new cells.
And like any manual that gets copied over and over and over again, typos start to creep in.
Exactly. And it's not just copying errors. Your DNA is constantly under attack.
From what?
From everything. UV rays from the sun, chemicals in your food, background radiation, even just the normal chemical reactions of your own metabolism are creating byproducts that damage your DNA.
But we have ways to fix that, right? The body isn't helpless.
Oh, it has amazing repair crews. Armies of enzymes that rush in and they patch the breaks, they fix the typos. But as we age, two things happen. One, the damage starts to accumulate faster than we can fix it. And two, the repair crews themselves start to get a little old, a little sloppy.
So the instruction manual gets filled with more and more typos.
And if one of those typos happens in a really critical gene, say a gene that tells a cell when to stop dividing,
you get cancer?
That cell can become cancerous. That, in a nutshell, is genomic instability. The blueprint is degrading.
Okay, so the instructions are rotting. Then there are the telomeres. I feel like telomeres had this big pop culture moment a few years ago. Everyone was talking about them.
They did, and for a very good reason. The classic analogy is the little plastic tips on the ends of your shoelaces.
The aglets.
Yes, the aglets. Telomeres are these protective caps of repetitive DNA at the very ends of our chromosomes.
So they don't actually code for anything important?
Nope. They're just buffers, sacrificial material, because every time a cell divides, it has to copy all of its chromosomes. But the way the copying machinery works, it can't quite get to the very, very end of the strand.
So a little piece gets snipped off each time.
A tiny little piece of the telomere gets chopped off. The shoelace tip gets shorter and shorter every time you tie your shoes.
Okay.
And eventually, of course, the tip is gone. The shoelace starts to fray.
And what happens in the cell when that happens?
When the telomeres get critically short, the cell senses that its important DNA is now exposed and vulnerable. It hits the panic button.
And it stops dividing.
It stops dividing completely. This is called telomere attrition. When you start running out of telomeres in your tissues, those tissues can no longer regenerate properly.
And this leads us directly to my absolute favorite term in all of biology. It sounds like a title for a horror movie.
I think I know where you're going with this.
The zombie cells.
Cellular senescence. It's incredibly evocative, isn't it?
It's perfect. So explain this to me. Because usually when a cell is damaged or its telomeres are too short, it's supposed to do the honorable thing and, commit suicide.
Correct. That's a process called apoptosis.
Programmed cell death.
Right. It's a safety mechanism. The cell basically says, look, I am damaged. I might become cancer. So for the greater good, I'm going to dismantle myself.
But sometimes that mechanism fails.
It fails. The cell doesn't die, but it also doesn't divide. It enters the state of suspended animation. It becomes a senescent,
A zombie.
a zombie. But here's the nasty part. It's not a quiet zombie that just hangs around. It's a loud, toxic zombie.
Oh, great.
These cells develop something with a terrible name. It's called the SASP, the senescence-associated secretory phenotype.
That sounds like a terrible band name.
It would be a very loud, very angry band. These cells, they just start spewing out inflammatory chemicals, cytokines, enzymes that degrade the tissue around them.
So they're poisoning their neighbors.
They are basically screaming, "I am damaged," at the top of their lungs. And in doing so, they damage their healthy neighbors. They can even turn their neighbors into zombies, too.
It's contagious.
In a way, yes, within the local tissue. And this is a huge contributor to something called inflammaging. This chronic low-grade background inflammation that just simmers in older bodies.
And that's connected to everything.
Everything. It drives atherosclerosis in your arteries. It drives Alzheimer's in your brain. It drives arthritis in your joints. It's like having a small, smoky fire burning in your house all the time.
Wow. Okay, so just to recap, we have the instruction manual rotting away. That's genomic instability. We have the protective caps on our DNA wearing off. That's the telomeres.
Right.
And we have zombie cells setting fires in the living room. That's senescence. And we haven't even talked about the power plant yet.
The mitochondria.
Right. We all learn it in high school biology.
Yeah.
Mitochondria are the powerhouse of the cell.
They are. They take the food you eat and the oxygen you breathe, and they turn it into ATP, which is the chemical energy that runs everything.
But these power plants are dirty.
They're very dirty. Burning fuel creates exhaust. And in this case, the exhaust is oxidative stress, free radicals.
Which are these molecules that just bounce around and damage things?
They damage everything. They damage the cell, and critically, they damage the mitochondria themselves.
So they're self-destructing.
Over time, yes. As we age, our mitochondria become less and less efficient. They produce less energy and more toxic smoke.
So the lights in the house start to dim.
Exactly. It's like swapping a brand new clean electric engine for a 50-year-old diesel truck that's just spewing black fumes everywhere. Your cells literally run out of the energy they need to do their basic housekeeping.
And this is just a sample, right? There are other hallmarks we're not even getting to, like loss of proteostasis, stem cell exhaustion.
There are. But the core idea, the central thesis of geroscience, is the same for all of them. That these are not mysterious acts of God. They're not some vague spiritual decline. These are biological mechanisms. They're chemical reactions.
And if they're chemical reactions,
we can theoretically intervene. We can develop drugs to fix the DNA. We can find ways to extend the telomeres. We can invent therapies to kill the zombies. We can tune up the engine.
which sounds incredibly hopeful. It really does. But this brings us to this massive philosophical and even historical hurdle. Because if aging is just this collection of biological mechanisms, does that make it a disease? Or is it still just natural?
This is the natural argument, and it is the oldest debate in the book. I mean, Cicero was writing about this in 100 BCE.
Wow.
He wrote a whole treatise called De Senectute on Old Age, and he argued that old age is a natural stage of life to be embraced, provided one cultivates the mind and stays active.
Right. And historically, medicine has drawn a very bright, clear line. A disease is a departure from normal. If I have the flu and you don't, I am the sick one. I've deviated. But if we both get wrinkles and lose some muscle mass when we're 80, well, that's just normal.
Since everyone ages, it's considered normal. Therefore, by definition, it cannot be a disease. It's a logical loop.
It is. If everyone on Earth caught a common cold at exactly age 25, we might just think the sniffles were a natural developmental stage, like puberty.
We probably would. But the counter-argument, and this is pushed really hard by groups like SES.
That's the strategies for engineered negligible senescence.
Right. Their argument is that natural doesn't automatically mean good.
Smallpox is natural. Hurricanes are natural.
Being eaten by a tiger is very natural. The SENS view, which was really popularized by the biomedical gerontologist Aubrey de Grey, he argues that health is simply the absence of pathology, the absence of damage. Since aging causes damage, loss of function, pain, and eventually death, it fits every single clinical definition of a pathology we have.
So they're saying that accepting aging as natural is just a form of fatalism.
It's a coping mechanism.
Right. We developed it because for 100,000 years we couldn't do anything about it.
It's Stockholm Syndrome. We've fallen in love with our captor because we couldn't imagine escaping.
That's exactly how they frame it.
But now that we might finally have the tools to start picking the lock, The question becomes, do we still want to stay in the cell?
And this isn't just some high-minded debate for philosophers. This specific question of definition disease or nature, it actually sparked a massive global incident.
It really did.
Which brings us to our second big area today, the active debate. Because the World Health Organization walks right into this minefield.
They certainly did. This is the whole story of the ICD-11 controversy.
Okay, so set the scene for us. First, what is the ICD, and why does a boring list of codes matter so much to everybody?
The ICD is the International Classification of Diseases. It's effectively the Bible of global medicine.
The operating system.
It is the operating system of global health. It's maintained by the WHO. Every time you go to a doctor anywhere in the world and they diagnose you with something, that diagnosis corresponds to a code in this book.
So if you break your leg, there's a code for that. If you have malaria, there's a different code.
Exactly. And that code determines everything. It determines how treatments are tracked, how insurance companies pay out, how governments allocate billions and billions of dollars in public health funding.
So it's a very big deal.
It's a huge deal. Now, for years, the ICD gets revised every so often. And in 2018, the WHO was getting ready to release the 11th revision, the ICD-11.
Okay.
And in this new revision, they decided to introduce a new code.
The code was MG2A.
That's the one. And the label they originally gave this code was old age.
Just old age.
Old age. So that's it.
So I could go to my doctor feeling a bit tired, maybe my knees hurt a little, and my official medical diagnosis could just be old age.
That was the implication. And, you know, the intention from the WHO's perspective was actually somewhat practical. They weren't trying to be mean.
What were they trying to do?
They wanted a way to record data for patients who were clearly just declining, but didn't have a specific named disease like cancer or diabetes. They wanted a way to capture that general frailty.
But the backlash was immediate.
It was a revolt. It wasn't just a few angry emails. We are talking about major, powerful organizations. The Gerontological Society of America, the American Geriatric Society, AARP, International Civil Society groups. They were furious.
What was their argument? Because on the surface, old age seems descriptive enough.
Their core argument was that this single code codified ageism into global medical practice.
Wow.
It pathologized a normal life stage. If old age is a disease code right alongside cholera and syphilis and Ebola, you are effectively saying that being old is in and of itself an illness.
It implies that if you are 80, you are inherently defective just by existing.
Exactly. And the fear was that this would lead to lazy medicine.
How so?
Well, imagine a 75-year-old goes to the doctor with fatigue and some confusion. If the doctor can just slap on the code for old age, they might just stop looking for a real cause.
They might miss a treatable vitamin deficiency or a thyroid problem or depression.
They might just pat them on the shoulder and say, well, you're old. What do you expect?
That is a terrifying thought. It's clinical ageism.
It is. The critics argued it would lead to older adults being viewed as a burden, as a problem to be managed rather than as people to be cared for. It was a really heated, intense battle. There were open letters, emergency meetings in Geneva.
And the WHO actually blinked. They caved.
They did. In 2021, after all this pressure, the WHO officially walked it back.
So they got rid of the code.
Well, not entirely. They didn't remove the code because, again, they still need to track that data on frailty. But they changed the label. They stripped away the words old age.
So what is it called now?
Now, code MG2A is officially labeled aging-associated decline in intrinsic capacity.
That just rolls right off the tongue, doesn't it?
Yeah. It's a mouthful of bureaucratic salad, for sure. But the words really matter.
Why?
Decline in intrinsic capacity describes a state of a capacity to function is lower rather than an identity. I am old.
I see.
They also added another code, XT9T, for aging-related. The whole point was to keep a pathway for clinicians to document biological decline, the frailty, the loss of resilience, but without the massive stigma of that label, old age.
But here's where it gets really complicated. Because while all the anti-ageism groups were cheering the removal of that label, there's another group of scientists, the geroscience people we were just talking about, who actually want aging to be called a disease.
Yes. This is the pro-disease label camp. And their argument has nothing to do with stigma. It's about money and regulation.
It's all about the FDA, right?
It is entirely about the regulatory pathway to getting a drug approved. In the United States, the Food and Drug Administration, the FDA, approves drugs for specific indications. Usually, yes. And currently, the FDA does not recognize aging as an indication.
So let me get this straight. If I'm a brilliant biotech company and I invent a pill that perfectly repairs your telomeres and clears out all your zombie cells, and it demonstrably makes people biologically younger, I can't sell it.
You can't sell it as a treatment for aging because legally, in the eyes of the FDA, aging isn't a medical problem that needs a treatment.
So I'd have to prove it cures a specific disease, like heart failure or macular degeneration.
You'd have to wait for the dam to burst in one specific spot before you're legally allowed to sell the concrete reinforcement.
That seems backwards.
It is. And because you can't get an indication for aging, insurance companies won't pay for it, Medicare won't pay for it, and if there's no payer at the end of the line...
The big pharmaceutical companies, the Pfizers, the Mercks, they won't spend the billions of dollars it takes to run the clinical trials in the first place.
It's a classic market failure. The incentives are all wrong.
This reminds me so much of the whole fight over obesity.
It is the exact same playbook. Think back to, say, 2010. Obesity was largely viewed as a lifestyle choice.
Right.
A failure of willpower.
Right, not a medical condition.
But in 2013, the American Medical Association officially declared obesity to be a disease.
And that changed everything.
It opened the floodgates. Suddenly, it was a legitimate medical condition. Research funding poured in from the government. Insurance coverage expanded. And now, a decade later, we have this whole new class of drugs, the GLP-1 agonists like Ozempic and Wegovy, that are completely revolutionizing the field.
So the pro-disease camp is arguing that aging needs its obesity moment.
Exactly. They're saying we need to label it a disease to unlock the resources required to fight it.
So you have this impossible situation. On one side, you have the sociologists and the geriatricians saying, don't you dare label it a disease. That creates horrible stigma. And on the other side, you have the biologists and the drug developers saying, please, you have to label it a disease, otherwise we can never cure it.
That is the central tension of the entire field right now. And there's even a third argument, which is the resource allocation fear.
Okay, what's that?
The fear that if we officially label aging a disease, we'll shift all of our societal focus from care to cure. Meaning, do we stop funding nursing homes and Meals on Wheels and basic geriatric care and instead dump all that money into high-tech, speculative biotech that might only end up helping the wealthy?
The tech bro fear.
Yeah.
The idea that we'll have billionaires living to be 150 while the rest of us are struggling to get basic care in our 70s.
Correct. And frankly, even the scientists themselves can't agree on the basics. There was this fascinating survey by a researcher named Cohen where they asked top aging researchers some very simple questions.
Like,
is aging programmed into our DNA? Or when does aging actually begin?
You'd think they would have a consensus on that.
There was a massive consensus gap. A huge disagreement. Some said aging begins at conception. As soon as the egg is fertilized, the clock starts ticking down. Others said it begins at puberty, when growth stops and decay begins. Others said it begins around age 30. If the experts can't even agree on when the race starts, it's very hard to write the rules for the race.
Well, while the philosophers and the policymakers are all arguing about definitions and what to call things, there are people on the ground who are just trying to get the job done.
Yes.
And this brings us to our third section, the frontiers. Because regardless of what the WHO calls it, there are trials happening right now that could change everything. And the big one, the flagship, is TAME.
The TAME trial, yes. Targeting aging with metformin. If you follow longevity science at all, this is the holy grail of clinical trials. It's the one everyone is watching.
And the man behind it is Dr. Nir Barzilai.
Yes, from the Albert Einstein College of Medicine. He is just a force of nature. And the brilliant, almost subversive thing about the TAME trial is the drug they chose to test.
It wasn't some futuristic billion-dollar gene therapy.
No, they didn't pick young blood transfusions or some exotic molecule. They picked metformin.
Which is, it's a diabetes drug.
It is probably the most boring drug in the world. It's been used for 60 years. It originally comes from the French lilac plant. It costs pennies per pill. It is generic.
So why metformin? Why this incredibly boring, cheap drug?
Because we have mountains and mountains of data on it. We know it lowers blood sugar. That's what it's for. But over the years, doctors and epidemiologists started noticing something strange.
Okay.
People with type 2 diabetes who were taking metformin often lived longer than people without diabetes who weren't taking it.
Wait, hold on. Let me get that straight. The sick people taking the drug were outliving the healthy people not taking it.
In some very large observational studies, yes, that was the finding. And they also seemed to get less cancer, less cardiovascular disease, less dementia.
What is it actually doing in the body?
It seems to hit multiple of those hallmarks of aging at the same time, just a little bit.
So it's not a silver bullet, for one thing.
No, it's more like a tune-up for the whole system. It activates an enzyme called AMPK, which is a master nutrient sensor in our cells. It basically tells the cell, hey, we might be running a little low on fuel, so let's tighten our belts and start recycling and repairing things.
It mimics some of the effects of calorie restriction.
Exactly. It also seems to reduce that oxidative stress from the mitochondria. It reduces that chronic inflammation, the inflammaging. It's what you'd call a dirty drug. It does a lot of different things, but they all seem to point in a pro-longevity direction.
So Barzilai and his team want to prove this in a rigorous, placebo-controlled way.
Precisely. The TAME trial proposes to recruit about 3,000 people, all between the ages of 65 and 79. Half will get metformin, half will get a placebo, and they'll track them for 6 years.
But you said earlier that the FDA won't approve a trial for aging. So how on earth did they get this past the regulators?
That is the Trojan horse brilliance of the TAME trial. The goal of TAME isn't really to prove that metformin works. I mean, that would be nice, but it's not the main point. The real goal is to break the regulatory deadlock.
Ow.
Dr. Barzilai went to the FDA and he negotiated with them for years. And he convinced them to accept a brand new kind of endpoint for clinical trial, a composite endpoint.
Unpack that for me. What does that mean?
Usually a clinical trial looks for one specific thing. Does this drug prevent heart attacks? Yes or no?
Okay.
TAME is looking for a cluster of things. They are tracking the time it takes for a participant to develop any major age-related disease.
So cardiovascular disease, cancer, dementia, or death.
Any of them. They've grouped all the moles together into one giant mole.
Ah, I see.
They're essentially saying, we are not treating the heart attack. We are treating the underlying vulnerability that leads to all of these problems. If the group taking metformin gets these diseases significantly later than the placebo group,
It proves that the drug slowed the aging process itself.
it proves the concept. And if the FDA accepts that data for approval,
Then the precedent is set.
the precedent is set. Aging, or at least this composite proxy for it, becomes a valid target for drug development. It opens the floodgates. Suddenly, every biotech company in the world can design a new, better drug, point to the TAME precedent, and say, we want to run a trial just like that one.
So metformin is the battering ram they're using to break down the regulatory door.
That is the perfect analogy. Even if metformin only extends health span by a year or two, the regulatory victory would be worth trillions of dollars to the field.
But here's the practical problem. 6 years is a long time for a trial.
It is.
And if we want to develop better and better drugs that might extend healthy life by 10 or 20 years, we can't run 20-year clinical trials. I mean, by the time the results are in, the researchers will be dead.
That is the time problem. And the solution to the time problem is biomarkers.
We need a way to measure aging now in real time. We need surrogate endpoints.
It's like checking the oil in your car. You don't have to wait for the engine to seize up and explode to know that it's damaging itself. You just check the dipstick.
We need a dipstick for human aging.
Exactly. And the TAME trial is also designed to test a whole panel of these potential biomarkers. They're looking at blood markers, things like IL-6 and CRP.
These are proteins that measure that inflammaging we talked about.
Correct. They're looking at something called GDF-15, which is a distress signal that our mitochondria send out when they're struggling.
Okay.
But then there are the clocks. And this stuff, to me, is just absolutely mind-blowing, the epigenetic clocks.
The Horvath clock, named after Steve Horvath. This was a huge breakthrough around 2013.
It really was.
So explain this as simply as you can, because epigenetics can get confusing for people.
Okay, let's go back to the cookbook analogy. Your DNA is the cookbook. The recipe for you is written in the text.
And that text doesn't really change over your life.
Correct. But as you cook, as you live your life, you spill things on the pages, you get grease stains, you stick little Post-it notes on certain recipes saying, don't make this one or make this one constantly.
So the text to the recipe is the same, but the notes and the stains change how you use the book.
Exactly. Those notes and stains are chemical tags. One of the most common is called a methyl group. And these methyl groups attach to the DNA and they turn genes on or off. Horvath's incredible discovery was that these methylation tags accumulate in a very specific, predictable pattern as we age. It's like clockwork.
So you can take a drop of my blood, look at the methylation patterns, the Post-it notes on my DNA, and tell me exactly how old I am.
Yes. He can tell you your chronological age with incredible accuracy. But more importantly, he can tell you your biological age.
The age of my cells. Not the number of my birthdays.
Precisely. You might be 45 years old according to your driver's license, but if you smoke, if you're chronically stressed, if you have a terrible diet, your methylation clock might say you're 55. You are aging faster than you should be.
And on the flip side, if I exercise and eat well and sleep, I could be 45 but biologically 35?
Yes. And the newer clocks, which have these terrifying names like Grimmage.
Grimmage. Scientists really need to work on their branding.
It is dark. Grimmage can actually predict your time to death and your risk of disease with startling accuracy, just from those methylation patterns.
But that's incredibly useful for research.
It's a game changer. Because now, if I have a new anti-aging drug, let's say it's rapamycin or a senolytic that kills those zombie cells, I don't have to wait 30 years until you die to see if it worked.
You can just measure my Grimmage before and after.
I measure your Grimmage before the drug and 6 months after the drug. If the clock turns back, we know we're on the right track. It allows for rapid iteration.
That is the key. But the challenge, I assume, is validation.
That's the billion-dollar word. We still need to prove to the FDA that turning back the clock actually means you live a longer, healthier life. We think it does. The correlation is very strong, but it hasn't been definitively proven yet. That is the validation gap.
So we have the trials, like TAME. We have the dipsticks, like the clocks. What about the actual interventions themselves? What's in the pipeline? You mentioned rapamycin.
Rapamycin is currently the gold standard in animal longevity studies. It's the most robust molecule we have.
How much does it extend life in mice?
Depending on the study, up to 25, even 30%, which is enormous.
And how does it work?
It works by inhibiting a pathway called MTR. MTR is another nutrient sensor, and inhibiting it basically tricks the body into thinking it's fasting. It turns on all those cellular repair and recycling programs.
But you can't just take it casually, right? It has serious side effects.
Correct. It's a powerful immunosuppressant. It's actually used in organ transplant patients to prevent their body from rejecting the new organ. So you're more vulnerable to infections.
So not ideal for the general population.
Not at its current dose.
Yeah.
But there are companies like AOV and Pharmaceuticals that are working to develop analogs, new versions of the drug that have all the anti-aging benefits without the immune suppression.
And then there's the really sci-fi stuff, the reprogramming.
Epigenetic reprogramming. This is based on the work of Shinya Yamanaka, who won a Nobel Prize for it. He discovered a cocktail of just 4 proteins.
The Yamanaka factors.
The Yamanaka factors. And they can take an old specialized cell, like a skin cell or a liver cell, and reset it all the way back to a pristine, embryonic-like stem cell.
It's a factory reset button for the cell.
It literally is. It erases all those epigenetic marks, all those post-it notes. And now you have these huge, well-funded companies like Altos Labs.
With billions in funding from tech billionaires.
Billions. And they are trying to figure out if we can use this technology to partially reset our cells in our bodies. Not all the way back to zero, because that would cause tumors.
Right.
But just enough to make them functionally young again. It is very high risk, but the potential reward is just enormous.
Okay, so the science is moving at warp speed. The regulatory walls are starting to crack. But we have to ask the big question. What happens if this actually works? And that leads us to our final section today, the implications. Because if people start living to 110, 120, and they're healthy, that changes everything about society.
It fundamentally breaks all of our current economic and social models, but not necessarily in the way you might think. We're used to talking about the silver tsunami as a disaster.
Right, that's the dominant narrative. We have too many old people, they aren't working, they're drawing pensions, they're clogging up the hospitals. The young people are going to be crushed by the tax burden to support them.
That is the sick aging model. But the health span movement completely flips that script. This is the whole argument behind the longevity dividend.
I've seen this number thrown around, and it's so big it sounds fake. $38 trillion.
Yes. Economists like Andrew Scott at the London Business School have modeled this extensively. They estimate that extending the period of healthy human life by just 1 year
Just 1 year.
could add $38 trillion to the global economy.
It sounds impossible.
Yeah.
How do you get to a number that big from just 1 extra year of health?
It's the compound effect. First, you save trillions and trillions of dollars in direct healthcare costs. If people aren't getting dementia and heart disease and diabetes in their 70s and 80s, you aren't spending all that money on nursing homes and surgeries and medications.
Okay, that makes sense.
But the bigger factor by far is productivity.
Because in this future, 75-year-olds are still working.
Exactly. In this model, a 75-year-old isn't frail and retired. Biologically, they might be 50 or 55. They are experienced, they are wise, and they are still contributing to the GDP. They are still consuming, they are traveling, they are starting new businesses.
So the ROI, the return on investment, is huge.
The estimate is about 16 to 1. For every $1 we invest today in geroscience research, we could get $16 back in future economic growth. And this is why we're seeing these massive nonprofits like the Evolution Foundation getting involved.
That's the one based in Riyadh, right?
Yes. They are planning to invest up to $1 billion a year into this research.
That's NIH-level money.
It is, and their thesis is purely economic. They look at the numbers. The entire developed world is facing a demographic crisis. Fertility rates are falling off a cliff everywhere. We are simply running out of young workers to support our economies.
So the only way out is to keep the older workers healthy and productive for longer.
It might be the only way to save our pension systems and prevent economic collapse. In this view, older people go from being a liability on the balance sheet to being our most valuable asset.
But that brings up the dark side, the ethical questions. Access.
Always.
Yeah. I just can't help but picture the billionaire class hoarding this technology for themselves. If there's a pill that gives you 20 extra years of healthy life, and it costs $100,000 a year,
then we create a biological caste system.
a two-tiered society.
A society of the long-lived and the short-lived. I mean, if the wealthy can literally buy time by life and the poor cannot, inequality explodes into something we've never seen before. It's one thing to be richer than someone. It's another thing entirely to outlive them by 3 or 4 decades.
And it raises other questions, too. The lump of labor fallacy. If the 80-year-olds never retire, do the 25-year-olds ever get a job?
Economists usually argue that's a fallacy, that more workers create more wealth and more jobs for everyone. But it would certainly change the nature of a career.
You have to reinvent yourself constantly.
3 or 4 times. You might have a career at 20 and a completely different one at 50 and another one at 80. It changes the entire map of a human life.
It really does.
Yeah.
And we also have to navigate the different regulatory philosophies. We talked about the FDA in the U.S. wanting to treat a disease.
Right.
Europe is taking a slightly different approach, aren't they? The EM.
Yes. The European Medicines Agency, they've been a little more flexible. They focus more on function.
What does that mean in practice?
Well, they haven't been as obsessed with labeling aging a disease. Instead, they focus on maintaining intrinsic capacity. Can the patient still dress themselves? Can they manage their own medications? Can they walk up a flight of stairs?
It's a more practical, less pathological view.
It is. It's less about curing aging with a magic bullet and more about maintaining independence and quality of life for as long as possible.
Which brings us back, I think, to the ultimate goal. Because I don't think anyone listening to this really wants to live to be 150 if the last 50 years are spent frail and in a hospital bed.
No. Absolutely not. The goal is what a gerontologist named James Fries called the compression of morbidity.
The compression of morbidity. That's the mantra of the whole field.
It is. The idea is that ideally we want to live a long, very healthy, very active life and then have a very short, very rapid decline at the very end.
You square the curve.
You square the curve. You live healthy and vibrant to 90, 95, maybe 100, and then one day the light just goes out. You die young as late as possible.
That sounds like a much, much better deal than the long, slow fade that so many people experience now.
It is the deal we are aiming for.
So let's try to bring it all together. This has been a massive tour. We started with the fundamental biology, the hallmarks, the genomic typos, the zombie cells, the dirty engines. We looked at the political battleground, the WHO controversy, the fight over whether to call aging a disease.
We looked at the tools being built, metformin, the TAME trial, those epigenetic clocks that can measure our hidden biological age.
And we looked at the future, the trillions of dollars on the table and the really difficult ethical tightrope that we're all going to have to walk.
You did.
For me, I think the key takeaway is that this idea, this centuries-old idea of the inevitability of decline, is being fundamentally challenged for the first time.
It is.
We are moving from a passive acceptance of old age to an active engineering-based approach to creating health span.
We are. We are moving from sick care, waiting for the dam to burst, to true health care, reinforcing the concrete before the cracks even appear. And whether we end up calling it a disease or not, that shift is already well underway.
And that affects everyone listening. This isn't just about what might happen in a lab in 20 years. It's about how we view our own health right now. It suggests that our choices, our diet, our exercise, our sleep, they're actually a form of epigenetic engineering. We are driving the machine.
Absolutely. The manual may be written in ink, but we get to put in the Post-it notes. We get to decide how to read it.
Before we wrap up, thank you to all our partners, sponsors, and scholars who made this podcast and the research possible. We're truly grateful for your support.
And to our listeners, thank you for being part of this journey with us. If you enjoyed today's episode, be sure to subscribe and follow Stack Studios for more informative content, and support us on Patreon.
Brief pause. Until next time, stay curious, keep learning, and let the search for wisdom guide you forward. Have a great day.